Mouthwashes. Such an interesting topic, isn't it? Your patients are always asking about mouthwashes, which one to use, which one not to use, how to use. I've been using it for whole 10 years or something, never had any problems, all my gums are fine. Or I've been using herbal mouthwashes, but I don't know if it is effective. And you are left wondering, what is really good? At least when I was in dental school and when I was doing my residency, we read a lot about mouthwashes, but the most common mouthwashes that always was discussed was chlorhexidine or Listerine. And now with herbal mouthwashes, Periogen, so many mouthwashes are there in the market. And when your patients are going to ask you about it, you are not really sure what to do, right? So this video, I'm going to be talking about mouthwashes, the clinical aspect. I'll only give you a little bit of an theoretical information about the composition, which might help you to choose mouthwashes. This video, I'm not going to tell you what to do, what not to do. I'm going to be explaining about mouthwashes using literature, a systematic review article, which is a very recent article by very prominent faculties. And the reason will be using this systematic review to explain about mouthwashes is systematic reviews, like I've always explained, you can watch my videos on systematic reviews, is a collection of different articles. And if it's coming from very prominent authors, very prominent researchers, then you know they've used every possible source to come to an evidence-based conclusion. And that's what I'm going to do here. I'm going to discuss a systematic review. I'm going to give you a brief idea about different mouthwashes, their compositions, and from there, I'm going to leave you to make your own decision when it comes to tell your patients what to use, when to use, and how to use. If you don't know me, I'm Dr. Swati Gupta. I'm a YouTuber, I'm a dentist, and I'm specialized in periodontics from India. And if you like this video, please don't hesitate to like, share, and subscribe. Let's get started. So, different mouthwashes. Now, you know about Listerine, you know about chlorhexidine, but we do not probably we do not try to remember the ingredients as much, or we do not focus a lot on the ingredients. But in my experience, ingredient knowledge is really important when you are going to decide what to give to your patient, what to suggest them, because every ingredient has a different property. Let's start with the most common one, Listerine here. And again, I'm going to have my highlighter here so that I can tell you exactly, or you know what I'm doing. So let's start with Listerine. Now Listerine is active ingredient is eucalyptol or menthol, methyl salicylate. A lot of ingredients are there. But what are all these ingredients? All these ingredients are essential oils. And we're going to talk about essential oils. Again, I'm just going to give you a brief overview of what each thing is. Chlorhexidine is a bisbiguanide. And again, bisbiguanides, I'm pretty sure you've read about it, anionic, cationic action. So this is how chlorhexidine works. The 24-hour action, and this is considered as gold standard in mouthwashes. Most common other mouthwashes that you see are like Parodontax or Clauses. I mean, these are really available over the counter, and their ingredient is cetylperidium chloride. Again, this is kind of a product that has been known to work as an antiseptic, anti-inflammatory. There's a lot of controversial data when it comes to these ingredients. You have something called as Shield. You have TheraBreath, the active ingredient of which is sodium bicarbonate. We're going to talk about bicarbonates. You have peroxides, Peroxyl, 1.5% hydrogen peroxide. Most commonly, they are giving these mouthwashes. You'll read even the indications on the mouthwashes. They are for sores, for ulcers. You can use it. Very recently, hydrogen peroxide based perio trays are there. You'll find them I mean, if you Google, you'll find it. Hydrogen peroxide, as we all know, has a caustic action. So how does it really work is again controversial when it comes to saying, is it really effective when it comes to being used as an adjunct for periodontitis? You have something called as PMID, the active ingredient of which is stannous fluoride. Then you have something called as tooth and gums tonic. You have Perogen mouth rinse, Perogen toothpaste. So the reason of me of here giving you so many examples is to tell you that the ingredients, like I'm going to really stress here about the ingredients. Ingredients is variable in every mouthwash. So you cannot just say that a patient comes to you and says, I have bad breath. So you'll say, okay, let's use chlorhexidine. I can prescribe you chlorhexidine. Or a patient comes to you and talks about, I have a lot of ulcers in my mouth, and you'll say, okay, let's use chlorhexidine mouthwash is a gold standard. Every mouthwash has an indication based upon their ingredients, and sometimes some mouthwashes which are there in the market, they are there, but they might not be really that helpful, and I'm going to talk about it through the systematic review. Okay, so once you know the gen composition, let's talk about each product, each ingredient here. Most commonly, what I'm seeing recently, the patients that they tell, they're using something where the ingredient will be bicarbonate. Now, bicarbonate, if you know, is alkaline in nature, right? So its primary function is to regulate pH in the oral cavity. And the 1% solution is known to be said as, it can be used as mild mouthwash to neutralize acids, moisturize, and decrease the number of bacteria. It is also able to disrupt biofilms without an antimicrobial effect. So when you come to think about any mouthwash that contains sodium bicarbonate, it doesn't per se has an antimicrobial effect. It's basically working to disrupt the biofilm. It's neutralizing the acids. So how effective is sodium bicarbonate when you're trying to use in a patient with gingivitis, or you're trying to prevent gingivitis progression to periodontitis? Well, that's something that you have to read about. You have to understand and think about it, because how bicarbonate is working is just neutralizing the acids. So it's creating a buffer action. Like that's what bicarbonate is used for. It is being used for a buffer action. But can it really prevent progression of gingivitis to periodontitis, or will it be useful in a patient of periodontitis? You can think about it, you can read about it. So I'm not going to give you a conclusion, but I'm trying to have you think about things based on a logical understanding. Okay, let's go to essential oils. Now, essential oils are basically what? They are your aromatic compounds like menthol, thymol, eucalyptol, eugenol, and often you will have them in dentifrices, mouthwashes, in your toothpaste. They're all there for flavors. But also, these essential oils, they have germicidal, antioxidant, anti-inflammatory, local anesthetic, analgesic effects. So yes, they do have good properties of antioxidant, anti-inflammatory. So if your patient has a lot of inflammation going on for some reason, and you, or maybe any kind of a condition that can cause a lot of sores, and you want to have a soothing effect, or then you can use these mouthwashes, essential oils, right? And so like Listerine, basically Listerine has what? Listerine has menthol, eucalyptus. So the Listerine is also considered one of the very good mouthwashes that has an FDA acceptance, seal of acceptance, because of a germicidal effect. So yes, you can think about using essential oils also for cases where you are trying to achieve some germicidal effect. Coming to fluoride compounds, a lot of mouthwashes are fluorides. So the most common compound of fluorine that is used in mouthwashes is sodium fluoride. Other than that, actually, also another one that's commonly used these days is stannous fluoride. And stannous fluoride is showing in research that has a similar or slightly higher anti-caries activity compared with non-stannous fluoride. So initially, most of the compounds were having sodium fluoride, but stannous fluoride is another very highly researched compound. And also, recently, a lot of mouthwashes will have stannous fluoride because of its little bit higher anti-caries activity. So, stannous fluoride reduces calculus formation halitosis, and dentinal hypersensitivity. So fluorides we already know. Fluoride, then whenever you think about fluoride, you're thinking about anti-caries action. So if someone says I'm using fluoride mouthwash for periodontal reasons, for gum reasons, you would be thinking why exactly. So how it works is it reduces the calculus formation and also halitosis. So halitosis again has different reasons, but if the reason would be, patient has a lot of plaque in calculus, and I'm not really sure if you are aware, but calculus formation is not necessarily because the patient is not brushing well, but some patients are high calculus formers, like they have a tendency to have more calculus, and early, or I would say faster calculus formation as compared to some patients who would be in the category of patients who do not have very heavy calculus formation very faster. So you might have a patient who comes every 6 months recall, but every 6 months you'll see heavy calculus formation, and the patient will tell you, I really brush well. So it's not they're not brushing well, it's just that they have a good tendency to form calculus faster. In such patients, yes, you can always consider using fluoride mouthwashes, but should you always use it? Should they be like on lifelong using mouthwashes? We are going to again discuss that via the systematic review. Okay, but stannous fluoride reduces calculus formation, dental hypersensitivity. Again, we understand because of its occluding the dentinal tubules, and halitosis. And also, they can be useful in the prevention of enamel erosion. Understandable because fluorides are for remineralization, right? They prevent remineralization and they promote remineralization. Ethyl alcohol. Again, most of the mouthwashes are alcohol containing. So, ethyl alcohol, it's used as a polar solvent in mouthwashes and used as a solubilizer, stabilizer, flavoring agent, preservative. It has an antiseptic, anti-plaque adjuvant. Again, focus on the word adjuvant, right? That means it's being used as an adjunct. You can solely cannot depend on mouthwashes, and we are going to discuss more about it. So, ethyl alcohol or alcohol we know has an antiseptic effect. Now, it itself is not genotoxic or mutagenic. So, you have probably read about this that if you use alcohol based mouthwashes on a very long period of time, yes, they can make the patient more prone to oral cancer. But very important thing to understand is that ethyl alcohol itself is not genotoxic or carcinogenic. It's the byproduct acetaldehyde, which itself is a carcinogen. And these things, when I'm discussing, I just find it very helpful to explain my patients, because this is the time when all your patients can read, they go on Google, they read, and anything that you tell them might be misunderstood by them, and then they might be judging, oh, does my doctor really even know what is it? So yes, that's why whenever I'm telling you things, I'm trying to tell you the most critical information here, so that you can tell your patients or have a discussion with them about different products. Now, having discussed this about the different compounds, the different ingredients, ethyl alcohol, citalpidem chloride, chlorhexidine, I'm going to now go to the systematic review. And here I have to, and I'm going to be discussing about what are the guidelines according to the systematic review. And this is a systematic review. It's not exactly a systematic review, but it's a concluding article. A concluding article is basically where they use different guidelines and they compile the evidence and come to an evidence-based conclusion. So this article has been released in 2023, and very prominent people, researchers from University of Michigan, Plymouth University, University of Hong Kong, they compile some evidence, and I'm going to discuss everything that they discussed in this article. There are other articles about different facts, and you can read that, but I like this because of its again compilation of every guideline, European guideline, Australian guideline, and the American Association guidelines. So let's focus on some things that are highlighted here. So one thing that I like is yes, I'm going to go a little bit slow here. So let's discuss the consensus recommendation. Let me open the highlighter again. Okay, and it seems I cannot. But so the consensus recommendation of the European Federation that says that chlorhexidine mouth rinses should be used for a very limited period of time, and they should be used as adjuncts to mechanical debridement. And this is really important because what happens is some patients think that if they've been using chlorhexidine mouthwashes for the longest period of time of their life, they do not really have to come for recalls because somehow, again, everyone is reading Google these days and the information can be really misconstrued. And patients tend to think that if they use mouthwashes, everything is going to be fine. No, mouthwashes are an adjunct. I tell that literally to every patient I see, and mouthwashes are not a substitute. So that means mouthwashes are an adjunct, and that adjunct means that should be only used for a limited period of time. You cannot use an adjunct for the infinite period because it is used as an adjunct. It's not. Chlorhexidine mouthwash or any mouthwash should not be used for infinite period of time. They only should be used for a limited period of time. The European guidelines further point out that chlorhexidine use must be weighed against the side effects, which is like tooth staining, altered state. And again, you must have read about this. There are a lot of side effects. Patients are using chlorhexidine, especially chlorhexidine mouthwashes. So in countries like the US, where it's a prescription mouthwash, maybe this is not really used on a regular basis, but in certain other countries, it is over the counter. And there you will see patients having a lot of brownish staining. And also altered taste sensations has been noticed in such patients. So yes, chlorhexidine, and for that matter, any mouthwash should not be used for an unlimited period of time. It is not to be used on an everyday basis without any indication for it. Australian therapy, Australian guidelines. Sorry, my page is gone. Australian therapeutic guidelines. Now they say that the mouthwash is usually not even required as a part of a standard oral hygiene routine and should not be used as a substitute. Again, I think this is this is pretty understood fact that they are not to be used as a part of a standard oral hygiene. It does not have to be there in your bathrooms. And it should, I mean, unless it's been indicated for some reason. When the mouthwashes were introduced only as an adjunct in certain patients who were like on orthodontics, have braces, and they're not able to brush properly. So yes, their mouthwashes can be used for a limited period of time for as long as the braces are there because they're not able to maintain hygiene. So they have anti-plaque effect and antigingivitis effect. So mouthwashes can help there. They are used by certain patients who are not able to with less manual dexterity, or patients are not able to brush properly. Yes, they can be used by those people, but if you can brush properly, if you can maintain hygiene with your toothbrushing, you do not need mouthwashes just because you've been diagnosed with periodontitis. And now because you're diagnosed with periodontitis, the patient will go to a store and buy periodontax or periogagen or any other thing that says anti-plaque and anti-caries effect. And you as a doctor, this is your responsibility to tell the patients all about this. Okay, let's go to antiseptic. Now, the use of antiseptic mouthwashes in periodontal disease is controversial. They're only effective against supragingival plaque, and they're not effective beyond the gingival crevice or the periodontal pocket. Again, antiseptic mouthwashes, they are only effective against supragingival. So this is really important. Like I was bringing up the topic of periodontitis. So very often patients ask, "Oh, I have periodontitis." When you tell them you have periodontitis and you have a lot of, bone loss happening, then they'll say, "Okay, I actually saw an ad saying, this is very good for the periodontium, or there is an anti-plaque effect, and I know I'm forming a lot of calculus," because this is what I tell them: why periodontitis started, or you have a lot of plaque, right? The mouthwashes are only effective against supragingival plaque. So they're not really going to help if you have periodontitis and already you are in the stage of early periodontitis or moderate periodontitis. It's not going to really work. So there's no reason telling them or telling a patient, okay, start using a mouthwash and it will help with your periodontitis. It's not. It's only good for supragingival plaque. Short-term use in patients with gingivitis or necrotizing gingivitis when inflammation restricts normal toothbrushing, then they can be beneficial. Again, there are reasons to use them. There are indications when you should be using them. Coming to, again, Australian guidelines say that they have to be used only for a short period of time, and they even suggest 2 weeks to minimize any side effect. Brown discoloration, buccal cavity, margins of dental restoration. They are talking about chlorhexidine specifically is a highly researched compound, and most of the side effects they often talk about, but this also goes for any other mouthwash also, that it has to be used for a limited period of time. Alcohol containing mouthwashes may be associated with oral cancer, should be avoided. And we already read about it, that ethyl alcohol is known to cause, is not really associated, itself does not cause oral cancer, it's the byproduct. But regardless, any alcohol containing mouthwash is associated with oral cancer. So you have to understand. And patients with dry mouth, oral mucosal diseases, they definitely should avoid it. And this is something why you should know about alcohol containing mouthwashes, because there are non-alcohol containing mouthwashes now. So if you feel that a patient has a dry mouth, xerostomia, or any other oral mucosal disease, so these mouthwashes can make the condition bad or even cause burning sensation. So you can always tell them that okay, there are non-alcohol mouthwashes, and they can always use that if there's an indication to use a mouthwash. Cosmetic mouthwashes are without any bactericidal or bacteriostatic property. And we know that the one that are basically used for bad breath. Essential oil containing antimicrobials are recognized as effective against plaque and gingivitis. So they're also talking about different mouthwashes. So you have cosmetics like for bad breath, essential oils for anti-plaque or gingivitis, therapeutic like chlorhexidine, cetylpyridinium, hydrogen peroxide, which are literally antimicrobial. Again, hydrogen peroxide, still more studies are needed to understand how exactly and how effective it could be, because hydrogen peroxide is caustic. And then let's go to, again, mouthwash use for each patient needs to be considered on a case by case basis. So this is what I'm talking about, that you have to understand about mouthwashes have to be considered case by case. You cannot literally make it an everyday talk with every patient saying, uh, you can use this product, you can use this product. Yes, I am a pro for chlorhexidine, or I'm a pro for Listerine. Yes, keep using Listerine, keep using Listerine. No, every patient indication would be different based on their medical history, based on the problem that they're having, and based on what problem you want to avoid in future. Okay, let's go a little bit down. And also, this article goes on to say that the strongest evidence so far on adverse effects has been acquired through randomized trials. And although in many areas not enough research exists for a systematic review. So we do know about chlorhexidine. This is the most highly researched compound. But again, the evidence for everything is very limited because of the limited trials. And when we talk about their benefit in caries, so sorry, I said I'll be going slower, but yes. A Cochrane review has demonstrated that chlorhexidine used as an adjunct to mechanical cleaning in patients with mild gingival inflammation reduces plaque and gingivitis. Again, not considered to be clinically relevant at that time, but yes, in today's time, it is considered that chlorhexidine mouthwashes can be used for moderate to severe gingival inflammation. What do you understand by moderate to severe gingival inflammation? That means if your patient is coming with a lot of inflammation, you see a lot of plaque, you see a lot of calculus, it's not like you will put that patient on mouthwashes immediately. You have to understand if the patient is able to brush, that means they're not brushing properly. But if the patient has braces, is an orthodontic treatment, or the patient is old, they do not have manual dexterity, or for whatever reason they are not able to brush, those patients you can use these as an adjunct. And for supragingival inflammation, I mean, if you're seeing a lot of inflammation where it's like pseudo pockets are there, the inflammation is there in their gingiva, and yet it has not really so the reason for using it would be not um, to cause any to treat periodontitis, but the reason would be to make sure that at least that inflammation is not there. Okay, but again, this is an indication for certain category of patients. You should always remember it. Let's go to caries, and already we've talked about it that that certain mouthwashes like your sodium fluoride, stannous fluoride, all of these have good effectiveness for treating or for preventing caries, fluoride mouthwashes specifically. But in a Cochrane review, it was also demonstrated that they showed no additional effects. Now, I have to tell you something here that all these, you will find this article in my description. But when you read an article, just do not go by what is mentioned. I often, whenever I see a recommendation for something, I often click on it and then go to the original article and even read it from there, because this is a very good way to read an article, just to not go by what you read, but also to go and read the references for yourself and understand what extra they might have said, what might have been missed. So I'm telling you the things that I mentioned here, but I did read all these references before, and just to make sure that nothing was misinterpreted somehow, and that can happen. Even famous researchers and authors can somehow or sometimes misinterpret. So always read the articles on your own also. Okay. Fluoride mouth rinses are more effective when used at another time than brushing. And this is something, again, patients do not know. And I've often seen the dentist also do not tell their patients, you should never brush and rinse the same time. Brushing and rinsing, they have to be at separate time if you really found if you really want the effective result. You do not otherwise, it's basically, I tell everyone, if you are doing something that you not even know how to use it, fluoride and then mouthwash is an expensive form of water. That's it, because you're not working, you're just rinsing, and that's it. There's no effect of it. So if you want an effective result when you're using mouthwashes for any purpose, and it's indicated, they have to be used in a proper way. And the proper way is there should always be a 30 minutes difference between your brushing and between your mouthwash. Or if you are the kind of person who does not like to brush at night, or so I would say just do mouth rinsing at night. That's also there. I'm not here suggesting do not do twice a day brushing. All I'm saying is that there always have to be a gap, and if you're the kind of person who does not brush at night for whatever reason, just at least do rinsing, because there has to be a gap. Okay, so summary and recommendations for clinicians. Now, antiviral effect of mouthwashes remains uncertain. Most of the mouthwashes are of limited use to manage periodontal diseases. Fluoride mouthwashes are recommended for prevention of caries, okay, and as used as an adjuvant or adjunctive to in patients with high caries risk. And these are some of the important things that are highlighted. Mouthwashes can reduce supragingival plaque and gingival inflammation only. Remember, they do not have they do not penetrate the sub-G area. Mouthwashes should be used for a short-term period. There is evidence supporting use of chlorhexidine and essential oil-containing products. If you are considering consulted about mouthwash used for the management of halitosis and in-tooth whitening, there is lack of in vivo clinical trials to confirm the evidence. Avoid advocating the use of mouthwashes in patients with good health or low caries risk, because otherwise you'll cause something called as microbiome dysbiosis. And dysbiosis is basically you're altering the microbiota by using antimicrobial mouthwashes in healthy patients when it's not even needed. It's similar to your gut health. If you're using a lot of probiotics for any reason, again, you can read a lot of articles on probiotics, but the concept is if you're eating a lot of products for no reason, it's only going to cause dysbiosis. And do not advocate the use of alternative mouthwashes available in health food stores, because again, there is no such evidence that supports the use of such products. So I hope that you've understood that mouthwashes are not a substitute. And when it comes to explaining your patients about mouthwashes, at least with this video, or if at all, even there are two things I want you to understand and tell your patients is that mouthwashes are not a substitute. And if you want to use a mouthwash, the patient should understand that there is no proof that over-the-counter herbal products or any kind of essential oils that says anti-plaque, anti-gingivitis, anti-caries, there is very less clinical evidence so far because the studies are limited to say that those are effective. So mouthwashes should not be used as even if they use an adjunct, they should not be used for the whole life. They are used for a very limited period of time, 2 to 4 weeks, that's all. And they should not be used on a longer period of time, any mouthwash for that matter. And always, if you are prescribing a mouthwash, there has to be a time difference. There has to be at least half an hour difference between rinsing and a mouthwash. And so far, the only two mouthwashes that have the FDA seal of acceptance are chlorhexidine and Listerine. You can use chlorhexidine or Listerine, but decide based on the patient's condition which one is the one that you want to prescribe them. If you are prescribing, or if you're telling them to use over-the-counter Listerine or non-zero, non-alcohol or zero Listerine, which doesn't contain alcohol, there should be an indication. If you still have any doubt about mouthwashes, even after reading this article or watching my video, please feel free to comment on this video, and I'll be happy to answer your questions. And again, if you like this video, like, share, and subscribe. I'll see you in the next video.